In terms of some kind of broad overviews of what I'm hoping to cover, I want to ask you to think about mental health and understanding mental health problems as not something that's focused solely on a person or something that is within them alone, but the idea that mental health problems are something that's developmental often and that involves an interaction or an experience that involves the individual as well as their contexts, their environments, both in terms of the development and the experiences they've had over time as well as their current contexts. I think that's really important to set the stage because we don't want to place all of the responsibility for care or for treatment, or change on the individual alone. I think we can also think beyond a label like autism to thinking about the idea of transdiagnostic processes. We'll also hear more about that tomorrow over the keynote. But within the field, both of research and within clinical practice, we're starting to really consider moving away. And this has been there for quite a while, but more recognizing now the importance of moving away from a diagnostic-specific approach to understanding the experience and the processes that are at play and targeting those experiences and processes. And then I want to briefly tease you to think about, well, what do we know around targeting individuals and targeting families and targeting communities? And is there a case for each of those? And what is that case? Okay, and then I hope that by the end of the day, at the end of the talk, you'll go off to the other, you'll hear from the other talks, and some of these things will have connections. Having not seen what the other people will be actually presenting, but just looking at the titles, I feel like there will be. Okay, so as a clinical psychologist, I always like to joke, and if you've heard me talk here before, I came and spoke about thriving in autism. I always like to joke that if you don't start with statistics, the college will take away my license. It's also a sad fact that it's relatively easy for me as a researcher to write that part of a research grant where I'm supposed to justify why this is an important topic. There's no kind of debate anymore that people on the spectrum experience higher rates of mental health difficulties than would be expected in the general population. We find this when we look at community-based surveys of parents where people report a 4 or 5-fold chance, or when we look at psychiatric interviews and we're starting to go through structured psychiatric kind of interviewing where up to 70% of adolescents and adults will meet criteria for at least one psychiatric condition. And that's even after taking great pains of trying to dissociate or separate what might be symptoms of autism and what might be other symptoms. For example, if you have autism and you're also very socially anxious, is that anxiety, maybe that's just part of the experience of having difficulties in a more social or unstructured social situation, or is it more than that? So even when they do those kind of great pains, many times they find much higher rates of mental health difficulties, anxiety, attentional problems, depression. And now a word of caution, there is some very emerging research to show that even in those situations where we take great pains to try to separate out what is ASD symptoms or autism symptoms and what are mental health difficulties, sometimes we tend to overestimate the actual percentage of diagnoses. But even in those situations where people revisit other studies and other data and they take an even more conservative approach, rates are still much higher. This is a slide I typically show because I feel like it tells an important additional message to what I just said. I mean, I guess all of my slides I think are important, that's why I put them up there. But why do I think this one is important? So a number of researchers from the UK where they love their census and they do a very good job of surveying at a population level. Were able to survey, as part of their standard census, they actually inquired about mental health and behavioral difficulties in children and youth across the countries in the UK. And these researchers were able to drill down and find out, this at the whole population level, they were able to drill down and find out which families had children identified with autism, which ones were identified with an intellectual disability without autism, and which ones had both an intellectual disability and autism. And then they were able to compare on this parent report survey, rates of clinical or meaningful clinical mental health difficulties, at least in 3 dimensions, something like attentional problems or hyperactivity, behavioral problems, and emotional problems, broadly speaking. And that really is about anxiety and depression. So what do you really see from this slide? Well, the first bar that you guys see, the lowest one, 19, 22, 18%, that's the rate of these kind of clinically significant or meaningful difficulties in the general population in the UK of children and youth. Okay? So about 1 in 5, which is already important to recognize that mental health difficulties are not the sole purview of a conference or a talk on autism, that many children and youth are struggling with these kinds of things. Another piece is that, yes, if the next bar over, we see very high rates, much higher rates using the same scales when it comes to across these different dimensions. And then the yellow one, we see for youth who both have an intellectual disability and autism, very high rates. There's a third piece here, and that's for the youth who have an intellectual disability without autism. They also have significantly higher rates of the same kind of mental health difficulties or behavioral difficulties as their peers who are on the spectrum. So there's a message here around ASD, but it also speaks to how having developmental difficulties might place somebody at risk for mental health difficulties. That this is, again, not exclusive to the story of autism, but also that there are implications here for caring for people in general children in general when it comes to mental health. Whether you have autism specifically, whether you have another form of developmental kind of difficulty, or if you're not identified with anything. Now, in Ontario, we're publishing a study right now that's going to come up very shortly. So this is kind of pretty fresh in terms of the literature, where we were able to look at all of the young adults, 18 to 24 years of age in the province, who in their in their OHIP card, in their OHIP information, so their healthcare information at an administrative level, had some code of autism. Or actually 2 codes of autism, to be more specific, compared to 18 to 24-year-olds who have other developmental disabilities without autism. So Down syndrome, Fragile X syndrome, as a group overall, some other kind of code or flag. Because when you go to the doctor at some point, or if you've been assessed in a medical kind of field, they typically will enter at some point in your file, you'll have a code there. So we're able to work with ISIS in Ontario to pull together the administrative data. Okay? And this is through a project H-Card in Ontario, funded by the Ontario Ministry of Health and others. So and then to compare that to a randomly selected group of young adults in Ontario who don't have any developmental disability codes in their administrative health information. So that's like comparing 5,000, so we had around a little more than 5,000 young adults in Ontario with an ASD identification, compared to 10,487 young adults with another developmental disability other than ASD as an identification, compared to 393,000 or so, give or take, typically developing, or we should say, young adults who didn't have either of those two. Okay? And we could also look at what are the other codes that are in those files. So I'm just presenting you a little bit here to say that even in that sense, those young adults with autism have significantly higher likelihood of having at least one psychiatric diagnosis on their file at around 50% or 51%, compared to 38% of those young adults who have another developmental disability, compared to, again, about 20% or 1 in 5 young adults with no developmental disability. So this kind of information really does resonate with those same numbers we saw in the UK, but this is a totally different way of getting at that information. There were, interestingly enough, there were also, although much smaller, you see on the farther bars, we also looked at substance abuse or addictive kind of behavioral disorders, and you have much lower rates across the board, but even there we found significantly higher rates of substance abuse issues in young adults with developmental disability compared to the general population, and young adults with autism compared to the general population. There's no difference between those with developmental disability and those with autism. Okay? So this is not just a UK story. It's not just a parent report story. Okay? This is, there's a lot of convergence around mental health. No more stats for the rest of my talk, I promise. Okay? So you're all here. I'm preaching to the choir, right? You're here because you recognize this as an important issue. So let me plant some concepts, some ideas, right, that you can take away for the rest of your day. So one is that we've advanced this model. I published a paper a few years ago suggesting that we could think beyond a specific label, not just when it comes to autism, but when it comes to mental health problem that we're talking about. In many cases, we talk as if anxiety is the only negative experience in terms of emotional difficulty that a person might have. Certainly, if you look at the literature on mental health and autism, the vast majority of what comes out is anxiety specific in terms of the focus. Right? It is a very important issue. I'm not understating that. But what we also have found is that there's a relationship between having high levels of anxiety and having high levels of depression and high levels of anger, right? Having difficulties more broadly, that is, with emotion regulation, for example, or self-regulation. There are shared underlying mechanisms that we can start thinking about that people are starting to target, rather than a diagnostic-specific way of thinking about problems. The interesting thing here is that when we think about this, we're kind of moving away from the notion that if I can only treat you for anxiety, that means I can't help you for your sadness or your depression or the anger difficulties, because that's all I kind of see. We're moving beyond that now when how we think about mental health difficulties. So the same thing happens when we look at psychiatric diagnoses. About 80% of youth who have autism and another diagnosis of ADHD, attention difficulties, have an additional psychiatric diagnosis. Right? That these kind of psychiatric diagnoses, the average in the UK when they did this kind of study was, the median was 3 psychiatric diagnoses. So when there's one, there's typically another in that sense, or there's often, I should say, another. So these things are related, and even in the general population without autism, when we think about treatments of mental health difficulties, there's increasingly more interventions that are transdiagnostic in nature, where it's the same intervention that clinicians are using to target anxiety as it is that they're helping to target depression. And they can have treatment groups that have people with depression in the group, people with anxiety in the group, people with anger difficulties in the group, all together working on the same material showing gains. So there's still a lot of research we need to do there. But what I mean, and there's additional places within the autism field where the idea of transdiagnostic has been around for a long time. The use of applied behavioral analysis to address different types of challenging behaviors. The techniques, the technologies, the approach to treating those kinds of behaviors are not always unique to the actual presenting issue. Now, what you do, the actual thing that you're doing is going to be unique to the person. But the idea of thinking beyond the actual presenting problem to the bigger picture, I think, is very important. There are also people who are talking about associations and the special relationship, if you will, between symptoms of autism or difficulties that might be related to autism and these emotional or mental health difficulties. So Jeffrey Wood from I believe it was from California, came out with this, published this really interesting kind of conceptual model. So what he suggests is that we've got kind of these 3, let's call them classes or families, okay? In the first, he talked about ASD-related stressors. Okay? Now, ASD-related stressors, he's referring to these kind of little things that somebody living with autism might experience on a daily basis that are chipping away at them, that are adding these kind of stress, not these acute major crises, but they suggest 4 kind of examples of this. One would be social kind of confusion or the experience of being in an unfamiliar social world. That might add a whole level of daily stress that somebody with autism has to live with and often experiences. A second might be bullying and other kinds of victimization. We know that people on the spectrum are at greater risk of experiencing peer victimization. There's research, certainly in terms of bullying in the school system, but also beyond that, some of our work has examined experiences of sexual victimization in adults with autism, for example, or other types of interpersonal violence victimization. So these are kind of, sometimes minor, sometimes very major interpersonal traumas that people with ASD experience. The third they suggest was prevention of engaging in pleasurable activities. And I think that was very clever to kind of recognize. If I go to school and I'm really interested in a certain topic and I want to talk to you about that topic and that's really what I want to focus on. And because I'm in that school, in that class, and for some reason I'm not able to, I have to do something else instead, it's not I might be able to tolerate that and I might have to go along with that, but I'm still not being able to engage in what I really feel like I want to engage in, something that's important to me. It's this prevention of engaging, and in some ways there's a punishing feeling associated with that. And lastly, they talk about aversive sensory experiences. And we all recognize now the important role that we have to consider around sensory experiences in autism, hypo or hypersensitivities. And if you're going around your world when things are too bright or these smells or the textures that you feel are kind of grating on you, these are small daily things or kind of that will chip away. Now, you take these kind of ASD-related stressors, and the more you have these, the less you feel, the more you might feel anxious or depressed or have general negative affectivity. If you or I were going through that on a daily basis, I know it would impact me, right? So, and then we have these kind of higher levels of negative emotional experience. That actually has some effects. They suggest it has effects like maybe avoiding those social situations that are contributing to those daily stressors, or maybe wanting to engage more in those comforting activities or topics that reduce my stress, right? So if I'm feeling really upset and I'm feeling really sad about something, I might want to really focus on that one topic that gives me pleasure in my life, right? But what happens when you do these kinds of things is that this can loop back and cause more ASD-related stressors. And then we have this kind of negative feedback. So there's an association here between kind of ASD symptomatology or difficulties related to that and the emotional pieces that go back and forth.